guys do.
Yeah, it is.
I love it.
They
found out about the cup, Laura. Now. Eric's spidey senses were active.
No, that's not all bad.
Yeah,
So we're just leaving it.
Okay, so I'm going to go ahead and call our meeting to order. I know Rhonda is otherwise occupied. I'm sure she's having fun in Yakima. I'd like to call your, I don't even know the right word anymore. So I'd like you to take a look and notice the attestation of conflict of interest and self-dealings and all that good stuff. Please be aware of that. Don't do anything stupid. So thank you for that. Carol, you had asked me to kind of bounce around a little bit on the agenda.
Right. So, Mr. Chairman, I'd like to propose that we move the appointment of our public safety sector up to the beginning of the agenda so that he can participate in the voting of the other action items.
Excellent. I'd be happy to accommodate that.
Thank you.
Do we need to approve the consent agenda?
Oh yeah, we got to do introductions too. Yeah, we should probably do that. Thank you. You guys want to take a quick run around the table, introduce all these people? If that would be okay, why don't we start with me? I'm Brian Gibbons. I'm the treasurer. I represent providers, and I'm chairing the meeting.
Susan Grindle, CEO of Hope Source in Ellensburg, Washington, representing the social service sector on this board.
Eric Nelson, Kennewick Fire Department.
Sierra Foster, Australia Sunnyside Hospital. Becky Cullen, Greater Columbia.
Diane Halo, Greater Columbia.
Ruben Peralta, Greater Columbia.
Patrick Jones from Eastern Washington University's Public Policy Institute.
Darlene Darnell, Catholic Charities, representing a community faith-based organization.
Leslie Stalmacher, Educational Services for 2023, Quick for Education.
Julie Peterson, Kittitas Valley Healthcare in Ellensburg, I represent hospitals. Ronnie Batchelor, Lord's Health Network, I'm a consumer representative.
Sam Riddell, Greater Columbia.
Wes Lucky, Greater Columbia.
Tanya Energy Space Council. Tanya Chris, you represent the Yakima Nation. Carol Moser, Greater Columbia. Sandra Torres, Yakima Valley Farm Workers Clinic, representing FQHC. Dana Otis, the Lord's Health, representing behavioral health. Carrie Green, Three Rivers Community Foundation, representing philanthropy. Jenna Shelton, Greater Columbia.
Martin Sanchez, Greater Columbia.
Ruben Alvarado, City of Pasco, representing local government.
Excellent.
Joel Chavez, CHPW.
Kat Latay, CHPW. Horace Angles, Coordinated Care.
Very nice.
Ashley Fernandez, Greater Columbia.
Lauren Johnson, Greater Columbia.
Very good. Anybody up? Have another.
Community Health.
Nice to meet you. Dan, we're doing introductions. Nice timing. You're on.
Yeah, Ferguson, the Allied Health Center of Excellence, with the Yakima Valley College, representing workforce.
Excellent. Do we have folks on the phone?
Martha Lane here, Columbia County and Garfield County Public Health.
And one other.
This is Madeline
Okay, thanks,
Carlson.
Martha.
This is Madeline
Madeline.
Carlson, representing transportation and the secretary for the board.
Thank you all very much. So now we can jump around and add, have a discussion about Mr. Nelson. Eric Nelson with Kennewick Fire Department. You're going to be representing public safety?
Yes.
Okay. I guess we can-
Let Sandra take that.
Yeah, you want me to speak to that?
Please do.
All right, so as you know, John Sinclair's position on the board was vacated, and we had one little bit of business left over for the nominating committee, which was to find his replacement, and Eric Nelson was one of several who volunteered for this position. So we tried as best as we could to get everyone coordinated, right, Lauren, for a meeting and discussion about those who were interested in the position, and ultimately had to go through an online vote to get full sector participation. And the outcome of the vote was that Eric was chosen as the next representative. So we are thankful for your willingness to serve and be here today even. Always great when we can have as many people here as possible. So
That's great. Congratulations.
I would motion to approve Eric Nilsson as the new public safety sector representative.
Thank you, Sandra. So a motion and a second. Any discussion? Okay. All in favor?
Seconded.
Ronnie.
Okay.
All in favor?
Aye.
Hi,
Any opposed?
this is Jorge. Afternoon.
Good afternoon.
Hey, Jorge.
Congratulations. You're one of us.
Welcome aboard.
No going back.
Make sure you get your cup.
You know not what you have entered.
We can't tell you that. We can't tell you.
I actually read it in the minutes.
Yeah, you'll have to call me later, I'll tell you. Okay, so thank you all very much for that. Sandra, of course, a wonderful job with the nominating committee. That was a ton of work. So thank you very much for all of that effort. All right. So we've got it, as we reviewed the board minutes from the 117 meeting. I would entertain a motion for approval.
So moved.
Do we have a second?
Second.
Moved. Susan. Moved and seconded. Any adjustments? Comments? Okay. All in favor of approving the board minutes from the January 17th meeting? Please say aye.
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 Any opposed? Any opposed? Thank you very much. That motion is passed. So the next thing we've got up here is Greater Columbia staff. We're going to talk about the reports and updates. So Carol?
So we'll just go through each article as they are, they're in your newsletter. So the first is the network management for the opioid resource network, which is actually a board action later on during this meeting.
So I'll start on that. So we have put out an RFP for an opioid resource network manager. The due date is for this to be back to us is the 22nd of March. So we feel that and we'll explain it a little bit later on in the agenda. We're going to go into details about the data of why we chose Benton Franklin and Walla Walla County to be the next place for the opioid resource network. So I'm going to table that discussion for later.
Okay.
We talk about plan C.
So are we going in order?
You can go ahead.
Okay, and I'll do my other article. So the next article that I'm going to talk about is the regional summit for the opioid use disorder and trauma informed. So with partnered with Pacific Northwest University, we have decided to partner with them with our learning collaborative. So it started out as a learning collaborative, and now it's developed into a much more in-depth summit, and it has 4 tracks, and it has 5 keynote speakers, and the first day will be, the 19th will be open to the public, and we'll have a couple of speakers for the public, and it's going to be at Eisenhower High School, hopefully. That's the location that we are still trying to pinpoint down. But the rest of it will be held at the Pacific Northwest University's facility, and they have a beautiful facility, and they're going to donate it to us so we don't have to pay for a venue. So that was a big saving on cost. And I'm in the process of doing some fundraising for it. We're hoping to get some sponsorship. And so to cover some of the speaker fees that are we have about 26 speakers, so you can imagine that the speaker fees are quite high for that. So that's where we're going to start reaching out to see if people would like to sponsor that. And so that's everything about that. Oh, and then I have one more article. Sorry, my bad. I'm a busy person.
So registration will be through the PNW web.
Yeah.
Any idea when that'll be?
Currently, we just finished the outline of the website. We are finishing pinning down the speakers. We still have a few that are still kind of strugglers, so we want to make sure we have everything, and then once we get it all, we'll put it up. And yeah, it's going to be limited to the facility amount is 350, 400 people, so we definitely want people to get in and get registered. Right. So we'll send out the links to everybody, and as soon as we get that information out, I will send it out to you guys.
Do we have a cost for the registration yet?
So the cost, we were hoping that we'd be able to let our providers go for free, but unfortunately, with the food and everything, just to subset the cost, it's going to be about $100, $150 for non-CME and $200 for CME, because the CME, we have to pay $50 for the CME, so that actually doesn't go towards it at all. So she has a $50 fee for the CME. So, but it's great that we have opportunity to have the CMEs, because a lot of physicians and it's really open to a lot of different people. I mean, I think anybody could attend this and get really good information about trauma-informed care and about the opioid crisis and things like that. So, unfortunately, it will be $150 or $200 for CME.
And how's that fit to Learning Collaboratives?
Oh, and then we have one track that is pretty much all of our Learning Collaboratives. And the other couple of tracks there are parts of the Learning Collaborative as well. So it's going to count towards you for your Learning Collaborative that you need to attend for the practice transformation.
Okay, that sounds
Are you
good.
going to have any kind of scholarships available for people that want to attend but cannot afford to attend because they're not in a position of their agency's affordability?
We have not discussed that, but we would probably recommend
We do have a scholarship fund that you can access through the Benton Franklin Lynn, right, Ruben?
Yes.
Yeah, we can do that.
So, well, what I'm saying is not scholarship in that term, but like if there's other CHWs or if there's other peer counselors that would like to attend.
And that would be available
if you
through the
can-
Lynn scholarship fund.
They just have to apply for it.
To attend this.
Yeah, they can use this as a
And there's plenty of kind services happening in June.
And we'll be talking about that later today too,
Mhm.
the next item.
And we can always put something about that if we need to in somewhere. And that'll help.
Okay. The reminder is the dating, what's the date? It's in
June 19th through the 21st. The 19th is just in the evening for the public, and then the 21st is the full day. 22nd, it's done around 2:30, 3 o'clock.
Okay.
Oh, 21st. So the 20th is a full day. The 21st is till 3 o'clock.
Is the 19th going to, like, what's your limit on that day since the public?
And you bet, I think it's in a high school auditorium, and it's pretty big, so like 1,000. It's a pretty big facility, so we're hoping that, and that one, I think that one doesn't cost anything at all.
And we've set up a sponsorship prospectus for organizations who want to contribute financially to the event, with some reciprocating branding and other promotional items that come with that.
And I'll send that out as well. They're depending on which level of sponsorship you do, there is, like for registrations, there's things included in the amount that.
Okay, that's awesome. Thank you very much.
You're welcome. The next thing that I have is is the behavioral health providers moved into fully integrated managed care. So we've already been discussing this for a long time. They find, as of January 1st, they went into managed care. They are going to start the early warning system webinars starting February 28th. And this is where Healthcare Authority has put together the webinars regarding the indicators that we have, that they have developed, and so then now we're going to see the results. They collected some baseline data on some of them. Some of them they couldn't get baseline data, but it'll be a good place to see where we're at, especially the first one since we haven't had one yet. So I think it'll be good to kind of see what the numbers are and some of the trends and things that are happening.
Mm-hmm.
Also, we're still going to keep having the provider readiness work groups. We have one today, actually, after this meeting, that we're going to go over the pre-managed with them, and then there'll be a couple more in March, and then we'll just keep it as if they need anything, they can reach out to me or anything like that. That's everything that I have to talk about.
Okay. Are things going okay with that IMC piece? I mean, that's working out reasonably well.
Yeah, so far, it doesn't seem like there has been a lot of issues. They've been having those calls on Mondays and Wednesdays and Fridays, and now they're kind of wrapping those up.
Wow.
So,
That's a lot.
yeah.
Okay, yeah.
Joelle, you left, you're not with the DHO anymore, right?
No,
Okay.
HPW.
Okay. Other questions? Very good, thank you. Who? Becky. Becky is next.
Awesome. Okay, so this is the update on the payments that have been made out of the portal to our provider. So,
Payments made.
Disappeared.
Oh. Alrighty.
And there's your table.
Oh, the table's there, that's the important
Texas
piece.
MIA.
Yeah. So I changed this table a little bit from what I normally report on for our tracker. I wanted to show the 2018 year end is on that graph, and it shows that we paid $3.3 million out last year out of our portal to our providers, which is awesome. And then for the 2019 is what you see up there in the orange and white sections. And what I changed on here is I changed this to reflect the actual categories that are in the portal that I pay from, that we pay from. And so the first category on there is the community health funds, which is our third-party administrator contracts, and Ruben's going to talk about that later. But we have 2 contracts out right now with third-party administrators for our social determinants of health projects, and we have a couple more to go that we're working on getting signed. So that amount will go up when we get those contracts signed. Another one that we've been paying out of was the integration incentives, which was the last of our BHO contracts, which was mostly the contingency fund that you all know about. The next one's the provider engagement, and this is our practice transformation contracts, and I think it's really awesome that in the short amount of time this year, we've already pushed out $1.2 million. So I'm really proud of our navigators and team, Sam, and they're doing a great job. So the total for 2019 already is almost 3.1, and compared to what we did for the entire year last year at 3.3, we're going to see a lot of money going out this year, and it's exciting. That's
Wow.
it for me. Is there any questions?
Those are dollars out, not dollars committed, correct?
Yes, that's
That's
committed.
out.
Yeah, those are payments that we have made out of the portal.
Okay, that's good. Excellent. Les, right? Les is next on,
West.
I heard Les.
Go ahead, Les. It's okay, Ryan. We got it.
You're going to talk. Looking like, what? I didn't know I was on the agenda.
Wes, you're up.
All right, so
Thank you.
this is just an HIT update. These are a few of the initiatives. Carol and I will be talking about our 2019 timeline a little bit, where you'll see a broader extent of some of the additional initiatives that we're working on around this. CSI, as we've talked about, is the platform that we'll be using for a lot of different reasons, but a big reason is for our practice transformation organization to report out on their completion of milestone deliverables at a quarterly cadence. It's a really important part of our work. There are 3 other ACHs that are using CSI for a similar reporting platform. However, because our milestones are so unique and so extensive, it's going to take additional work. to build up that piece of the platform. CSI is going to have to bring in consultants. This extends the timeline, and unfortunately, it also increases the budget to this. So the contracting piece was finished just a week or two ago, and they're in the build phase of this right now. We hope to get that completed by the end of March, hopefully before the first quarterly milestones are reported. If not, there's a document that they can use to fulfill their milestones, and we'll get it done before the next quarterly reporting. The next piece relates to direct secure messaging. In terms of some of the real high priority goals of practice transformation, coordination of care is really foundational to our work, and we support that in a lot of different ways. The patient-centered medical home, that's one of the change concepts of that. But interoperability also supports coordination of care, and we're trying to support that through different mechanisms, including direct secure messaging, which links providers to providers and providers to community-based organizations to transmit information about the patients that they serve. We've, through a competitive process, we chose Data Motion as a vendor to work with us. There's an expectation that each practice transformation organization will have some sort of direct secure messaging technology. They can use a technology that might be built into their system, such as Cerner, which has a DSM built into its platform. For other organizations, they can choose to use another direct secure messaging technology. If they don't, then we would like them to rely on Data Motion. In our base population health funding, we've pushed out enough money for them to finance this technology, which frankly is not very expensive. So the other organizations that we want to adopt this technology include EMS. EMS, community paramedicine, we see playing a key role in our practice transformation work, so we want them to have the ability to be connected, at least through this, potentially also through pre-managed, which I won't go into right now. So we've set aside some funding to have at least 10 EMS organizations come into this system if they want to take on the technology. Mm-hmm. And again, the funding should cover implementation and the extent of the transformation project through 2021. A third item that's not on here that I'll briefly touch upon relates to the Health Commons work we're doing in Kittitas. We've talked about this before. They're essentially done with the HIT part of the pilot project, and they're at a point now where they're closing out some agreements, an agreement between KCHN and the Greater Columbia, as well as business associates agreements between KCHN and the providers that are party to that network. There's also a consent process that relates to 42 CFR Part 2, which has also been completed and built into the Health Commons electrical network. So when those first two pieces of the contracting become complete, the Health Commons goes from demonstration to production phase. And when that's finished, then we will work with them to split the monthly cost going out to the end of the transformation project. Coming up with the opioid resource network here in the Tri-Cities in Walla Walla, pending approval by the board, we'll also begin a Health Commons project tied to that work as well.
Remind me and the board again, and I asked this question over and over and over just because it's a big picture thing that I got to get. I don't have my head all the way in. Health Commons is when you're linking the different community-based organizations together. Is that correct?
For the most part, yeah. It's I mean, you can think of it as a referral management system of sorts.
That's right. Okay. Yeah.
Right. It starts with a very specific. We use this term use case, which is essentially a care pathway. It might be focused on severe persistent mental illness or substance use disorder. There's an organization that takes sponsorship, and then a few individuals who are party to that specific use case come on to build up. 80% of this really doesn't deal with the IT. It's just the organizations coming together to agree this is what the flow diagram looks like. And then once that's done, then the HIT gets applied only as it's needed in a very lean, efficient way.
I understand.
And once that first use case is built up, then the network that's been formed can say, we want to add additional use cases. And then they can add that to the Health Commons. And then adding additional use cases is very straightforward. a lot less intensive than that first pilot use case.
Okay. Yeah, and the reason I ask is because it's a little cutting edge, actually, kind of a lot cutting edge, and
it really is.
None of us have seen it, so it's.
Yeah.
I mean, practice with it. It's very cool, and I love it. I every time you go through it, I pick something else up. So I appreciate you sharing.
Keep
Yeah.
doing that, Wes. Keep doing it.
Well,
Expand his brain.
We really, there's a lot to it, and we're really fortunate to have found a consultant, Rob Arnold with Claudia Partners. I mean, he not only has the technical horsepower, but I mean, his heart is really into it, and he makes the connection between how this will really facilitate better health care. So what we've called these natural community of care.
Right.
So it's exciting work. We want to expand it into other areas as well.
Excellent.
So Brian, we might suggest that since Susan and Julie are both involved in the health commons, if you wanted to get any feedback from them.
Yeah.
Interesting.
Please do.
I have some follow-up questions on the direct care messaging. Have you already started doing outreach to folks that you've identified that would need the system? Is there like a perspective on this for those organizations that aren't identified because they have one who maybe may be looking to change their system? I just know there's a couple organizations who have direct care messaging, but they're not necessarily overly enthusiastic about the way it works. They thought it's operability. So I'm just wondering like what kind of information is going to come out on this.
Jenna, do you want to talk about that, Jenna Martin?
Sure. We've reached out to the sites that we have and just asked them just flat out, do you have direct care messaging, yes or no, and what EHR are you using? We did a kind of a demo with the direct care messaging vendor. We have DataMotion and with Prosser Memorial Health in Prosser, and just trying to just show like the capabilities that it has. So that's definitely a plan moving forward. We just wanted to get like our ducks in a row beforehand and know like who has what.
Right. I just know just with the timing. I mean, I know people are anxious to get work done, so it's like, has that already been rolled out?
Yeah.
Because it's not necessarily stated here. And then, is there a plan to show it more broadly in case there's someone who wanted to upgrade or change out their direct care messaging system?
And then in the future too, we'll be providing some of those technical assistance with direct care messaging more personally with each organization. You know, for the ones that are kind of struggling or don't like how it works, we can, you know, Jenna and myself and Sam are going to be getting hopefully some training and you know how to utilize direct care messaging more meaningful and kind of tailor it to each organization so they're able to use it to its full potential.
Curious.
Okay, that's very cool. You guys have anything else to add? Excellent. Thank you very much, Wes. Wes.
Les is down here, Wes is right there. You got it right.
That's good.
Get you right.
All right, I think Carol, the next one is the Housing Summit.
Right. So,
Thank you.
2018 was pretty much consumed with getting our model of care underfoot. So we decided on the PCMH model of care. We had a big effort to select providers, and now with that big wave of activity underway and implemented, now we can put our attention to other really important initiatives in our communities. What was interesting during the Leadership Council meeting today is I think almost every LIN has identified housing as their #1 priority. I think the only community that hasn't identified housing as its top priority might be Whitman. We haven't heard from them yet. So housing is just fundamentally, you know this, Sterling, is just a fundamental issue for people's health. Particularly in Benton and Franklin counties with reorganization for Lords, we're looking at more supportive housing. Lords was, as you know, purchased by RCCH, and then repurchased by LifePoint, and LifePoint really doesn't have an interest in owning its own housing stock. And so we've been working with Lords to say, so what can we do now? Because we definitely have people with chronic and persistent mental illness that have a very, very difficult time trying to find housing in our community. So we decided that we would put together all of the partners that are involved in housing in the Tri-Cities, our housing authorities, Lords, Providence, Ben Franklin Community Health Alliance, the cities, just to say, you know, how are we going to address this as a problem? And we're landed on a summit, and we're fortunate enough we have 2 people that are going to come down and talk to the group about their experiences with providing supportive housing in their own communities. Rhonda Huff being one of those people that will come down and talk about what Yakima is doing to address homelessness and chronic and persistent mental illness and supportive housing in their community. And then Rob McCann, who has done several housing projects in the city of Spokane. So that will happen March 19th from 2 to 4:30, and really we're trying to rally people around this issue before we take any further steps, because it requires a level of a commitment on the community to, once the capital project is built, to provide the services. So we need to ensure that this is going to be a sustainable project, and that whoever is willing to step forward and be the developer, that we've got their back. We want them to know that the community is really supportive of this idea, because when push comes to shove, at the end of the day, we know that these projects will be met with quite a bit of resistance. It's a fact of life, and so we just want our developer to feel comfortable coming into our community to do this work, because there's always a little bit of heat, you know, applied to those organizations. And Darlene, I think, is also going to be in attendance, but we just need to get those housing providers, you know, together, and then maybe take the next step. So we're really excited about this.
Do we know how big the problem is, or is it a strategy of anything is better than what we have now?
Well, with the loss of the Lord supportive housing, we're in quite a deficit,
Right,
and I
sure.
think that you guys only had like 12 spots.
We had a total of 22 beds available.
Yeah.
And it still was, you know, really a minimal impact.
Right.
Our community is really voucher heavy with, but actual homes available is difficult to find.
So I'm looking at this as kind of a model that we might be able to take to the
Yeah.
other communities,
Leverage
because
it
we're
up.
all suffering from a lack of housing stock, especially supportive housing.
So Carol, it is a priority in Kittitas County.
Okay.
Can folks from outside Benton Franklin attend this? Just to get
You're more than welcome to. I have a feeling that we will want to replicate this if it's successful, if this model works. You know, trying to collect all the people around. I don't want to send out any alarms. I don't want Ruben to get undue heat from your community yet. Because as it turns out, Catholic Charities, the Spokane Diocese covers Pasco and Franklin County. The Yakima Diocese covers Benton County. So it's not like that they can come over onto this side. So that's why we're working with Catholic Charities of Spokane.
Sure.
That I know that there's interest in Benton County as well as having supportive housing. So we're calling in both housing authorities of Pasco and Kennewick. Okay.
Yeah, part of the area of greatest need relates to what was formerly called wet housing. We don't like to use that term now, but it's essentially individuals who are still addicted and using
Low barrier.
low barrier things.
Now it is.
Housing first or low barrier housing.
So that's a particular need.
And we've got to get the right language.
Yes.
Yes.
You know, we've got
Thank
to
you.
practice the right language before the summit. So that's always good.
And really, the framework of that is that people are healthier once they're housed.
Yep.
And they're more likely to seek help, whether it's for substance abuse use or mental illness or other kinds of issues, if housing is a stable component of their environment.
If you look at the statistics around the homeless, their utilization of the emergency room, of inpatient, of substance use is much higher than those who have stable housing. So, you know, Maslow's hierarchy, if you don't take care of those base layers first, nothing else will work.
And we're going to tie in a little bit of economics with the presentation. Patrick's going to be there to facilitate the meeting, and we'll be giving us kind of a high-level overview of what are the economics around homelessness. It's a big issue when you're housing people in the emergency departments or in your hospital beds as opposed to just permanent supportive housing.
Right.
Unfortunately, they do not house them. They Cadillac's been known to send them off in the cabs, and it doesn't matter what time of year it is. Right now, I'm serving 4 different individuals that were sent out from the hospital with no respite beds to go to, and they're out on the street, homeless, because the mission won't take them, unfortunately, because of their use. And there's nowhere to take them to other than hoping that they can find some natural supports around them that they already know that they can go for a day or 2 here or there. But unfortunately, the vouchers for hotel or anything like that is exempt. There's programs that you can get into that might supply that for short term, but if you can't get into that system of care, then they're left out there in the cold. So you just have to be creative. I'm being very creative right now in trying to keep them inside at this cold weather coming back from an illness. So.
Well, and having you as a resource on some of these things is good for us too, right? As you guys try to build your model and your pilot, that's good. I really appreciate that. Other questions?
Carol, who is the intended or attendee for something like this?
Well, this is really kind of a meeting for the community of housing experts. We haven't ventured out into a community meeting yet. We just wanted to make sure that we kind of had all of our ducks in a row and our support infrastructure in place before we, go out and venture into the community.
Would it be something that you publish or just for them to?
We'll put you on the invitation list. It'd be great to have you there. It would really be great.
Okay. Very good. Thank you. Next item on our list is adverse childhood experiences with Ruben. All right.
So last month, the Communications Committee met and they decided to form a task force for the task force to guide us to ensure that ACE's resiliency media campaign is well targeted, is focused, is demographically sensitive, meaning culturally and racially sensitive, and as well as that it complements local efforts already being carried on in the local communities throughout our region. So the Communications Committee recommended 37 people, pretty much, a wonderful variety of people in the caliber and the expertise that they have. So far, 21 have confirmed or tentatively agreed to participate. So it's I think we're going to have tremendous success in like I mentioned, in the caliber of the people that are going to be part of the task force. The Pasco School District also enthusiastically agreed to participate. Michelle Whitney, the superintendent, she didn't hesitate at all to participate, and she volunteered her public relations people, the media people and the marketing people to assist in some of the more technical aspects of media campaign and things like that. So I was very moved by the responses I received from people when they answered their emails, and very, very enthusiastic. But the most moving one, it's here, I wrote it down. This person said, "I would be honored to be part of this work. Personal pain from the loss of my son due to ACEs and unawareness has fueled my desire to scream the message and help others prevent and heal." So I'm very excited about this work that we're going to embark on, and we're going to start pretty much meeting here as soon as I get responses, either accepting or declining the invitation to most people. So very exciting times coming up here.
Very good.
As a side note, one of the 2 scholars who coined the term ACEs and did the original research around ACEs will be one of the speakers at the Opioid Forum. We've invited him and he's agreed to come here. Dr. Vincent Folletti.
He has written extensively on addiction and ACEs, the connection between the two.
Wow.
Yeah, he's going to be one of the keynote speakers. He's really good.
Yeah, that's great. Other thoughts for Ruben?
I think you did doing a great job, Ruben. Keep it up, okay? Forward hold. Seriously.
Thank you very much. That's good. What's the next one we got?
Navigators.
Sorry?
Navigators.
Practice transformation.
So just a quick update.
I know you guys.
Hopefully.
Yeah, I've been seeing you.
Yeah.
Good, thank you.
Just a quick update on what we've been up to in the last month since we met. With this, nice weather we've been having. So, Jenna and myself have been kind of limited on visiting a few sites, especially, the ones here out east of us. The roads haven't been that great, but we have still been able to meet with them via GoToMeetings and Skype, which have been really productive meetings. We are able to answer their questions. They're able to answer our questions. They're able to see our screen if we have any materials that they need to see. For example, the toolkit, workbook, and their budgets, the templates, incentives applications that for their monies that they're going to receive. And so far, Jenna and myself have been getting good feedback on the workbook. No negative feedback so far or pushback. So that's been going good. And then, as we continue to work on practice transformation, if we're not able to, meet face to face, we'll utilize, this technology that we have available to us right now.
Right, you guys have a monitor.
Yep. So in our
Skype
boardroom that we have, we got some a TV, video camera, so we're able to utilize those technologies.
Excellent. Okay, other questions for these folks? Very good. Thank you. Lauren's up. Lauren, right? Lauren's up next. L.
Not Lauren.
Lauren. Maureen. I was going for Maureen, but you didn't go for that.
She's on right issues today. So the Healthcare Authority contracted with the Center for Community Health and Evaluation, GCACH, in 2016 to monitor the essential elements of collaboration of ACHs. And we recently received our results from 2018, the survey that was sent out, which we will be going over later today. But we were able to share those results with our leadership council earlier this morning, and then they were also able to hear from 3 local health improvement networks as well, which is something they had requested to learn more about, is the lens. So we're excited to utilize that survey to come up with other topics for future meetings. And then you can view the results. The link is below if you'd like. It's also in the board packet.
I might put Patrick on the spot here, Patrick, because since you led us through this exercise this morning, was there anything that stood out to you from the responses of the Leadership Council that you thought would be relevant to bring in front of the board?
No, so are
the areas
you going to go into the 2 or 3 questions?
Yeah,
or not?
but you can, from your point of view, what did you take away from this morning's meeting?
I didn't see, well, I thought the significant part about this morning's discussion was the suggestions came through. We did a little, for those of you who weren't there, we did a little real-time suggestion, discussion process. And my guess is for each question that we posed, there were 3, we got about 15 responses. So that was what I was most impressed by, was the number and quality of the responses and how to proceed with improvement. I don't know, how much you want, how further you want to go, but
We can actually bring up that Mentimeter to show some of the results if the board wants to see those responses.
We'll be discussing it later on. Really, community engagement, I think that's an area where all the ACH is struggling. And that's where we see the most promise with our local health improvement network, really is helping us with that area.
Okay, that's good. So we'll loop back around. Okay, great. And you have the next one too?
Yes. So the contract for the Greater Columbia region was awarded to Behavioral Health Ombuds Service, and this is a consumer-directed advocacy service. The ombuds will assist informally and investigate complaints related to your behavioral health provider. the Ombuds office is located at Greater Columbia Behavioral Health, and I have their address on there, phone number, and then I included the flyer, and I believe that has an email contact on there as well.
Who's heading that up? Who's gonna be?
Cindy Adams. Cindy, yeah.
Okay.
And I know that she was hoping to make it actually this morning. She wants to be more involved.
Is Ty Nelson still going to be involved?
No.
No?
That doesn't sound familiar, but I know
Okay.
Cindy is. No.
Yeah, Ty used to head that up.
Yeah,
She's not.
that's why I'm asking.
Ty Nielsen?
Yeah.
Yeah.
Oh, I know Ty.
Hmm.
I think he's, okay, I know.
Nelson.
Woman.
I think it's Nelson or Nielsen?
No,
I thought it was.
Ty Nelson.
Okay, but it's not the same
Yeah.
person. Okay, good.
Her last name is Simmons.
Mm-mm.
See, I got the name right.
Yeah,
Wrong
you
person.
did.
See how that worked? No, I got it. Wrong person. That's how it goes. All right, well, thank you all for that. Other questions to the staff on this? Very good. Next item we've got on our agenda, Ruben, is the Lynn tracker, correct?
Yes. So we're on this page here. The light green section is the 2018 Lynn deliverables, which they have all been met. The last one is the fourth row from the top down. That's the proof of financial stability. Everyone turned theirs in. So the 2018 Lynn contract deliverables have been met. The bottom portion, kind of salmon color, this is the community health fund deliverables, where Lynn is pretty much in going through the process of identifying their priorities on the social determinants of health for them to address. So Ben Franklin, pretty much they've selected their top priorities. They're just digging in a little deeper to add some of that language on the contract. The contract is pretty much completed, just waiting for that information for us to insert. The Blue Mountain Region Community Health Partnership, that one is actually a little further along. They've already captured the consumer voice. They're in the process of selecting their priorities, and they conducted over 200 surveys, and it's going to look very much like the other ones, I think. They're still going to take a look at some of the other information they've collected or they have from other sources, but I think at least a couple of the top ones it's going to include housing as well, just like pretty much everybody. Kittitas County Health Network, they've completed the process. Their TPA, which is the Yakima County Community Foundation, has received the funds. They will issue the RFPs in April. So hopefully by the end of April, early May, they'll be going through applications and deciding who's going to work on those projects. Kittitas selected housing and nutrition, right? Yes. And then Southeast Washington, their TPA has the contract right now. We sent it to them, and the language in the contract, pretty much, Becky, we didn't make a whole lot of changes from what we received from the Southeast Washington Health Network, right?
No.
So we're at that step right now where the TPA has a contract and it could be signed any day now. So, and after that, the funds will follow. Whitman, they will make a decision on the 27th of this month in their monthly meeting. They're going to be selecting between housing and food insecurity, and I think housing is one of the top priorities. And because of the amount that they're receiving, they're thinking that they're considering also working on some kind of resilience program with the schools, pretty much address ACEs. So they're considering that as well, and they'll be making that decision on the 27th of this month. Yakima, same as Kittitas, they've gone through the process. Their TPA, which is the same one as Kittitas, they've received the funds already, and their RFP process already went out. It's already closed. They received 20 plus applications, which what they tell us, that's higher than what they usually get. So everything's moving along. So we should be pretty much completed with this process, definitely by the end of March.
So has I'm sure I missed this, the Yakima land, that's Brenda's lunch, right?
Run and Dan.
Ron, yeah. Did you guys have a,
I know you're turning away.
so Ruben, do you know if they've got a list of what their focal points are? I mean,
Yeah, they
kind of like y'all were doing, housing and food insecurity, right? At Kittitas, were they doing the same thing?
Housing, transportation, employment, education.
Okay. That's interesting. That's good. Okay, that's great. Thanks. Is there anything else?
I can respond to that.
Well, that's an easy one, man.
Way to go.
Easy question.
Okay, thank you, Ruben. Any other questions for Ruben on this? Excellent. Thanks so much. Jenna and Martine, we're going to talk about practice transformation status tracker.
Yeah, so that is the document, the nice long colorful one. And what the main difference you'll notice on this document from last month is a 2018 cost analysis column that basically is a budget that mostly all of our sites for practice transformation turned in by the 15th, so last Friday, which was really, really good. We're in the process of revamping this document because right now it just shows like the 23 organizations, but we have 46 sites in total between Martine and I. So hopefully next month you'll maybe get 2 pages that show this by each site because each site is different. For example, if they have a hospital and 2 clinics, the hospital might get their milestones met quicker than the other 2 clinics. It just depends on that team and responses and all that good stuff.
Mm-hmm.
So we're hoping to be able to show that, and we're in discussion on changing some of these headers to really kind of directly correlate with the milestones, or at least put the milestone number that it correlates to next to it. So you will see updates next month.
Okay. Other questions? Other stuff?
No, just in April, you guys will see more dates filled in once those reports are turned in. So you guys will see this table will be filled out more.
Mm-hmm.
So.
Okay, very good. Thank you very much. Other questions for our practice transformation navigators? Gators.
Gators.
No, sir.
Oh, you being from Florida, right?
That's it.
Hey,
Les has a question.
Yes, Les.
Yeah, how does the stuff, providers have these myth things they're supposed to be doing, and some of these look similar. Is that, okay. No, thank you.
You just wanted the nod.
Yeah, they're actually, you know what, we're working our way through that. We're trying to figure out MIPS, and it's a pain in the neck. And, but what we have found at our place, as we struggle to understand it, is the MIPS data information and the metrics are very, very similar to what we've done with the DCMH stuff that these guys are doing. So that's been actually really helpful.
Yeah, I think the projects are really leveraging one another.
And Healthcare Authority, I think, thought about that. So there was alignment across different payment schemes.
And I remember coming back from DC, I don't even remember, 2 years ago must have been, when we talked about, I was struggling to figure out what the heck we were trying to do here. And I came back from this long meeting in DC where they were talking about where CMS was going. It was like all the same stuff. Mm-hmm. And so that they are very, very closely aligned. So that's good.
We've actually had that come up a lot. And so I know yesterday, meeting with Lords, they were trying to decide which of their clinical quality metrics, which is a requirement in practice transformation, to select at least 3. And so they were in that discussion, and then it came up like, oh, we have MIPS, so it would be smart to maybe not just choose like a super easy one like diabetic A1C, but also choose something that ties into MIPS as well. So it's come up a lot.
Yeah.
And it's had like the pleasant reaction of, oh, we might as well just
we're already here.
go with where we're going.
Yeah.
That's very helpful, I think.
Yeah, that's been really good.
And as long as we're in the weeds, we're doing ACO work as well. And again, it's just all really is tying together, and it feels less chaotic and more focused.
Mm-hmm. Yeah, you're right.
Interesting.
Okay,
So I
excellent.
do have a question for the navigator. So what is the expected timeline to get through this
for and Sam can jump in if we say the wrong thing, but 2019 is quarterly. We have a system right now where Martina and I are meeting with the site at least twice a month, if not if they need it more. And that can be in person or phone call just to make sure that they're meeting their quarterly milestones, because we don't want anybody to not get the full amount of money that they can. So.
And 3 months, every quarter they just fly by. This quarter we're almost done. So we want to, everybody to be ready to report, be on time so they don't miss out on any money. And as we work on this project, see the improvements that they have done within their organization as a result of active transformation.
It's a no child left behind approach.
Very nice.
Okay, excellent. Thank you all very much. Anything you got to do on that? The next couple of things we've got are action items. First one is the financial reports. Becky, real quickly, we met last week. I think myself, Rhonda, Jorge, and Julie, thank you guys for joining the committee. I thought we had a really good presentation. So would you like to kind of jump in?
Sure. Yeah, I thought it was a really great meeting. It was a little bit more descriptive than normal because we were trying to kind of catch Julie and Jorge up to what we do on that committee.
Remedial finance.
I hope it was okay for you guys.
Oh, man, the remedial finances with your treasurer.
So it was a good meeting. Thank you both very much for joining, and I appreciated that. So for the financials, so you guys have the balance sheet, the budget versus actuals, and the 2019 statement of activity in your packets. But what we're going to talk about is what's up on the screen, which is the roll up. So we won't go into a whole lot of detail, but as always, if you have questions, Brian's available. So the first box is our revenues, which you'll see our Yakima Valley Foundation money is still untouched and still there. Our design money, which we kind of changed to calling it operations budget for this year, is at $2.7 million. We have our AmeriGroup funding in there that is designated for social determinants of health that we haven't allocated yet. And then we're showing you so the district money is the money that is in our portal. So you can see we've got $24 million in there, and that's the money that's allocated for our providers for our project area.
Okay.
Going on down, we have our Numerica money market account, which we've got $7.4 million in there, and that is technically all of our operating money. And what's in the design funding up above the 2.7 is what is in what we're using for daily operations, basically. So it's kind of confusing the way that that's there, but hopefully not too confusing. I answer questions if there are any. In our expenditures, there's nothing too new in here. I don't think. You can see that we pulled down some money from the district funding for our payroll. We have our contract services, our facilities, which is mostly our rent and our phones. I don't think there's anything out of the ordinary in there that you guys don't normally see, but again, if you have questions, I'm happy to answer them.
Okay.
So our total expenditures are at $100,000.
So we went, in our committee meeting the other day, we went into some detail. As Becky mentioned, we made sure that all this stuff was in order. It's perfectly presented and very well understood by the staff. So I would entertain a motion to approve these minutes. Second? Motion and second. Any comments? Other discussion? Thank you. All in favor?
Aye.
Any opposed? That's aye in favor, right?
Yeah.
Okay. Very good. Thank you. That motion passes as well.
Thank you.
We spoke about Sandra, you took care of yours. Do we have anything else that you need to present?
No.
Thank you. Excellent work again. Okay, so we're going to talk a little bit Diane and Wes. We're going to talk a little bit more about the RFP on the network manager. Is that correct?
Yep.
For the opioid program?
Yeah.
Okay.
Wes
Thank you.
is gonna go first.
So do you have that PowerPoint? So, this is part of a data presentation that we've given to other settings, including the Franklin County Commissioner, Clint Didier, who came to our office. So some things here I'm just going to run over pretty quickly. Let's go to the next slide. Information here comes from the CDC and the Washington Department of Health opioid dashboard. Next slide. Very briefly, again, this is general national background. 2017, more than 70,000 people died from the use of illicit or illegal drugs. That's more than all the people that died from car crashes, all the people that died from gun deaths, all the people that died from HIV, more than all the people, all the Americans that died in total from the Vietnam War. Out of that 72,000, about 50,000 were tied to opioid overdose deaths. I will tell you that this number is tracking slightly downward along with the number of prescriptions, which we'll talk about. Next slide. This information comes from the Washington Department of Health opioid dashboard. There's a bit of a mix-up on this lower right or lower left-hand corner. These regions in color represent rates of opioid use. As you can see in Southeast Washington, it's very dark. Those are some of the heaviest rates in the state. However, we're talking about small populations, so we have to be careful in differentiating the total number of individuals and the rate per population. And looking at the total number of opioid prescriptions, Tri-Cities, which is Benton and Franklin counties, is highest for the total number of opioid prescriptions. Next slide. For the total number of chronic opioid prescriptions, which are those individuals who have been taking a prescription for 60 days or more, again, Tri-Cities is the highest. Next slide. For the number of individuals who are on both opioids and sedatives, such as Xanax, Valium, benzodiazepines, again, Tri-Cities is number one. Next slide. For the total number, this is the ultimate indicator, opioid-related overdose deaths. Tri-Cities had just over 100 for the 4-year time period ending in 2016. Next slide. So, I'm trying to decide if I should talk about this. So this relates to sort of a continuum of the movement from opioids into heroin use. In general, I'll just highlight one indicator on here. Around 5% of individuals who misuse opioid prescriptions will eventually transition to heroin. So the more people who are on prescription opioids, the resulting more people that will end up on heroin. Again, it's a small percentage of the population, but essentially there's a cause and effect there. About 80% of people using heroin first used prescription opioid drugs.
Susan, did you have a question? No, it's 80% of the 6%. Is that what your 80% is?
It's actually 80%.
So 80% of the 6, because
actually it's 80% of this. 80% of 25%. I know it's a little confusing. Again, this is not the emphasis of the presentation. If you want to talk to me more about the statistics, we can talk about this after the presentation. Let's go on to the next slide. So I'm going to let Carol talk a little bit about this. This relates to the opioid treatment networks.
Okay. It's in the S bar. I don't know if you.
I'm there for you.
It's Carol, not Beryl.
You're never gonna live that down.
Okay, it's just one more organization.
So when we looked at the state response to the opioid crisis, we found this map, and this map represents the grants that have gone out across the state through the Department of Human and Social Services, DSHS, that are administered by GCACH, Division of Behavioral Health. And what you notice is that there's a big gap from Okanagan all the way to Asotin without having any resource networks. Yakima did get one, I think with comprehensive mental health that has teamed with farm workers, YNHS,
Central Washington, Central Washington.
and the Yakima Health Department.
Yeah.
Yes.
Yeah. And so that's where you see those folks that are going out, and so they have tentacles into Kittitas County and probably down to Sunnyside.
Right.
But when you look at the rest of the state, obviously that there's a big missing block in the Benton and Franklin and Walla Walla area, which has some of the higher deaths and opioid uses. So we just thought we would bring that to your attention.
So, go
Real
ahead.
quickly, the next slide, please. This relates to our pay-for-performance measures, which we're going to talk quite a bit about here in a little while. But the ones that are highlighted in red relate to pay-for-performance measures that tie into the opioid project area. Follow-up after discharge from the emergency department for alcohol or drug dependence are measures that we're not responsible for until 2020, which is next year. But the remaining measures on their patients who are taking high-dose chronic opioid therapy by varying thresholds. So again, chronic means they've been on it for a while. High dose means they're taking above a certain dose threshold. Patients with concurrent sedatives prescriptions, as we talked about, that includes benzodiazepines and others. And then the last one, which relates to, which is important relative to what Diane's about to talk about, substance use disorder treatment penetration, relates to the number of individuals who currently have a diagnosis of opioid use disorder who are now receiving treatment either through MAT therapy or some sort of medication therapy. Next slide. I'm going to.
Okay, yeah, talk about it. We're going to talk about it soon.
Actually, I'm actually going to skip this because then I'd have to start talking about numbers needed to treat and I'd have to explain that. You want to talk about the timeline?
So we have a timeline right now. So the project started and they talked about the ORNs, and there actually were some people in our other areas that did apply for the ORN, the opioid treatment networks that are on the existing, but they did not receive them. So the only one in our region is the one in Yakima. In July, so we've updated the SAR for what we're doing, and then in January, we updated the status again of what we're going to do in the SAR. So now we're in the implementation of the opioid project, and so February 5th, we sent out the RFP for an opioid resource network manager for Benton, Franklin, and Walla Walla counties. And I'll tell you a little bit more about that when we get there, when we move to that. But then, so it's due to us by March 22nd, and then in April, we're hoping to have OHU or an outside technical reviewer score these for us, so that we're not objective. So they're objectively picking the person, so that it's not coming from us. It's coming from them by the technical what's in their RFP. And then in June, we're hoping that we will be able to start implementing the ORN. So if we go to the SBAR, and so you have the RFP is here, and in the back of it has the scope of work. The main thing that the network needed to have is either to be a MAT provider or have a collaborative agreement with the MAT provider, because that's one of the things that we are going to be graded on. And so that's where the numbers to treat. So Wes put together a numbers to treat, and it was 77 for the numbers to treat. So we upped it to 100. So this RFP is for 100 individuals for induction of MAT treatment. One of the main things we also said with in the RFP is that they needed to contract with our providers first. So anybody that's part of our network, and so that's where we put that in there.
Well, we just said preference.
Preferences,
Right.
yes.
Right.
We want them to be able to, you know, our providers to be able to benefit from this as well. Then they will also have to provide monthly reports to us. They have to comply with the PACE reporting requirements. And then they will serve as a bridge to help our practice transformation organizations get ready to case manage those patients with OUD. So we're hoping that this year will give them us enough time to train our practice transformation providers on how to case manage this. And it may turn out that these may be too high, you know, utilizers that those organizations may need to contract with a network provider in the future. But on the back is a diagram of how we picture it to be. So we're kind of building the bridge is what we're saying is like this network manager is going to help train our practice transformation organization on how to case manage these opioid use patients. So back to sure.
How did you, this seems so relationship dependent. You call out a number of times that they have to develop relationships and formal documents how did you decide on the weighting in the RFP? I noticed being a local provider is like 10%.
Well, we
copied.
Yeah.
So when we looked at the statewide opioid research network proposal, Julie, we basically copied and pasted a lot of what they had in their proposal and used it in our proposal. But I think that we added the piece around local providers because that was not necessarily a part of their.
I would just say that you gave it a 10%, I think, in the weighting in the RFP. And that to me just seems to be such a head start in this process. So that's just Julie's input for what it's worth. That seems really bad. No, I think it's more than 10% valuable in getting this started early and being effective on a short ramp. So.
Good to know.
Thank you.
So these have the same numbers that he had just showed you, but they're just a different way on the graph in the S-bar. This is just our way of showing you that Benton, Franklin counties are really the highest. They're the highest in our region. And Yakima is the second, but Yakima already has their network. So now let's focus on what doesn't have a network, and that's where Benton, Franklin, and Walla Walla. We added that because we felt like we could to do all three under one umbrella. And so, so there's $450,000 left in the district funding that's not allocated to anything as of yet. And so that's why I'm coming to the board to see if we could allocate the $300,000 that it's going to take for the opioid resource network to fund it. And so that's where I'm coming to the board for.
As the timeline said, we called this out in the project plan proposal in 2017. It's been part of our timeline and part of our SAR update. So this has been well documented to Healthcare Authority that this is one of the primary strategies under one of the 4 project areas that we're responsible for.
Is there any other, anywhere else that would otherwise be competing for this $300,000 leftover dollars? I assume them to be leftover dollars, right?
Correct. There was unutilized funds from last year that rolled into this year.
And they're allocable to something of this nature, correct?
Right. Yeah.
We still haven't allocated money to the opioid project and to the transitional project.
Right.
So those are the 2 projects that are needing to be funded. And so this would be part of the first.
See what I'm getting to?
Yeah.
I mean, I'm going to be really obnoxious, but I mean, there's real value in being the first one up, right?
Yes.
When there's, so, I mean, I know you guys have all dug through this, and do you have, is this a recommendation from the,
We took it to the Budget and Defense vote, but there wasn't enough people to vote on it that
So
were there.
we
staff
sent,
recommending though? I mean, is that what
Yes.
y'all want to use the
yeah,
dollars for?
but also just so you know, Brian, we sent out, because there wasn't enough people at the Budget and Funds Flow Committee meeting, we sent out a survey to all of the committee members and asked for them to vote on this, and only 3 of them responded.
That's okay.
So you were one, yes.
responded.
She's the chair, so I hope so.
I just want to make sure that, I mean, I want to be supportive of, I think as a board, we all want to be supportive of what the organization feels is the appropriate use of those dollars that have been allocated to you, right?
Yeah.
The program, and if this is it, then,
So the reality of it is that we don't get paid unless we move the numbers.
of course.
And PCMH is a little bit longer term return on investment. It's a lot of money, it's $12 million.
Mhm.
And, but if we don't move the numbers, then we're not going to get paid. So it's kind of similar to what the New York, Staten Island district, the PPS did, is that they used the model of care, PCMH as their foundation, and then they did these sprints and went after
Yeah, I
certain
understand.
particular areas that would give them a faster return on their investment. So we see this as one of those sprints, and looking at the statistic, knowing where we can get the most bang for our buck, because Yakima already has a network that they're building up, and we went and talked to Miguel Messina, who's overseeing that project, to get some ideas on the RFP. But we really think that this project is going to help us reach some of those data points that we need to get in order to earn money. So it's a little bit self-serving, perhaps, but on the other hand, if we don't make the numbers, then our providers don't get paid, which means our PCMH providers don't get paid. So it really is foundational. The other thing is that in the project areas, in the way that the money is allocated through the portal is that they give it towards certain projects. We have 4 project areas: bidirectional integration, transitional care, opioid use, and chronic care. So chronic and bidirectional are really taken care of under the umbrella of the PCMH. Opioid is really outside of that. So in the portal sitting right now, if we were to go in, it would say $1 million for the opioid use crisis. We haven't tapped into that money because we've usurped it, honestly, for PCMH. But since we have that funding left over, that $450,000 that we're not allocating for PCMH, we felt that this would be the highest and best use of those funds.
Okay.
And should the board decide not to go forward with this, we do have in the RFP a statement that says we reserve the right to not move forward with this RFP should the board decide that this isn't what they want to do.
Okay. Julie?
So are you looking for a motion to authorize move?
Yes.
With that background, I guess I would move to
Okay.
authorize the use of the $300,000.
Shannon?
I'll second, but I also just had a question related to the sustainability. Have staff done any research into like how we will sustain this beyond this year? Because I do agree with the comments that have been made. I agree with all the stats and statistics. We know how bad the opioid problem is in general in our region. And I think it's great that you guys expand this to Walla Walla, because I think that'll help pick up some of the counties that don't have as many providers and who rely on all 3 counties to access services. I'm just curious as to the sustainability beyond this first $300,000 for this year.
I can partially answer that. So concomitant with this at the same time, and again, we'll see our timeline for 2019. With the start of the opioid resource networks, there's also going to be a start to a health commons that directly overlaps with that. We are providing funding for that piece as well. That's already been budgeted. And Rob and the health commons will work to help create that use case, which will be specifically around opioid use disorder, which will help propel the network through the pilot project. Again, we will help cover half the cost for the operations through that. But there has to be a willingness on the part of the network to pick up the costs after the transformation project concludes. So that commitment to payment will help support sustainability of the Health Commons network, which is essentially the same thing as the opioid resource network.
But I just want to ensure that we're getting this network off to a good foundational start. I agree with, they will have to find a way to sustain beyond the
Right.
project period. That's without a doubt an obvious factor for them. I just want to make sure that they're off to their best start so
Right.
that they can draw in the resources that they need to leverage their sustainability long-term. If we're going to build something like this, I would like to see it last beyond the waiver process.
Right.
Absolutely.
And I think the other piece of that was what Diane brought up before was the opioid summit, is that in order to prepare our providers, so you'll see that the timing is we want to launch the opioid resource network in June, which is the same month that we're doing the opioid summit, that we're trying to plan it so that we give all of the providers a really strong foundation in becoming MAP providers, becoming trauma-informed care, and being available, having this opportunity to go to this summit that will give them a lot of information around this area. And then that whole piece of that learning collaborative and learning and training is part of the RFP so that our providers, our PCMH providers can, learn from this network. And quite honestly, I think this is a pretty specialized area. It could be one area, this complex case management could be kind of outside of CCACH, but at least it helps them grow that network of providers that they can lean on.
Right. Exactly.
Very good. I think there's a lot of grant opportunity out there too.
Mm-hmm.
Other comments, other questions before we call the question? Thank you very much. So,
I just have
yes, please.
a comment. I don't know if the board's aware. I'm certain that Greater Columbia Accountable Community of Health is aware that Blue Mountain Heart to Heart was vacated from their needle exchange in Pasco.
They have a new location now.
Yeah.
Right. But are we going to garner support with this network for those kind of outreaches that are going to support the healing of the communities? And
They'll be part of it.
They'll be
Okay.
part of the network.
I just want to be sure that that's all encompassing, not
Yeah.
just like it's being bipartisan or.
They're one of the spokes. The needle exchange is even one of the spokes in Yakima. So it's definitely a part of it.
Okay, good. Good. I'm happy to hear that.
And we hope to support syringe exchange programs, do some other work as well.
Okay, good. So we have a motion to go ahead and allocate these dollars to the opioid research network manager. Okay, all in favor?
Aye.
Any opposed? Okay.
This is Jorge. Brian, this is Jorge. We will be abstaining because we didn't get to discuss this, but we're generally supportive of the idea.
Very good. Thank you, Jorge. All right. Thank you all. The next item we've got on the agenda is the Lynn contract. That is also Becky and Ruben. Becky?
You want me to go?
I don't care which of you go.
Okay, so you guys have seen this Lynn contract before. We brought it to you last month, and there were a lot of recommendations from the board. We've also gotten a lot of recommendations from the Lynn's themselves. And so I think that everyone seems pretty happy with this contract the way that it is right now, and so we were looking for approval so that we can get it out.
Yes, I'd like to add one more thing. We had a conference call with all Lynn leaders, every Lynn had representation, and they had a chance to take a look at it. And on Friday, I don't remember any changes. We might have caught up one or two minor things. But,
there was the only one, and was that in the scope, we talked about submitting a budget for 2019, but we didn't put a date on it, when it was due. I think that was the only question that came out of that meeting. And so we addressed that in the milestone reporting schedule, and so we put it in the first milestone completion date, which is April 30th.
So we reviewed it with the local health improvement network leaders, and we took on many of their suggestions, and this is the end product of that for your consideration.
Okay.
Just want to say I appreciate giving time for the LINs to review this with their networks, because it's brought about some really great conversations, at least in Yakima County, on how we want to use the funding. So I appreciate having that time as you kind of wait for approval on this contract, because I think it was really beneficial. Good.
Excellent.
Thank you, Sandra.
So, and this is your recommendation to work with, right? This is the document y'all are recommending
Yes,
move
this
forward
is
with?
the final document.
Okay, so I would entertain a motion to approve the Lynn contract as prepared. Actually, you need to make the motion.
Oh. Move that.
Okay, now we could use a second.
Second.
Second. Okay, thank you. Additional conversation? Very good. Thank you all. All in favor?
Aye. Aye.
Any opposed? Thank you. Motion passes. Okay, so, Ruben, the next item on here, Lynn training request form and policy.
Yes, this Lynn training request form, I used, I think a couple months ago, December, you approved the sponsorship policy.
Right.
And that policy was to work with organizations that we're not currently funding to help sponsor any events they might have that support advancing our projects, GCACH's projects. So I used that policy as a template for this one. However, this one is specific to support local health improvement network active participants, for them to attend trainings or seminars or workshops, for them to go back to their local health improvement networks to pretty much help build capacity within their regions. So that's pretty much the, I'm just gonna go through the highlights here. So that's the main purpose. And each LIN gets $5,000 for the year. Let's see. They can attend. Also, they can bring in trainers to make their money go a little further. LINs also can collaborate, pool their money between 2 or 3 LINs to bring trainers or speakers to their regions. Also, if they choose to do so when they host a trainer, they can go ahead and charge a registration fee for any attendees that are not active LIN participants. Let's see what else. I said $5,000 already, right? And that's pretty much the highlights. I will have to make a correction though in the middle of the second page under eligibility. I'm gonna have to go back and remove the word event. It's there a couple times and replace it with training because that's a leftover from previous policy that I copied.
I hate it when that happens.
Okay.
Well, good, it says draft right across it, right?
Yes, and as soon as I saw it, man, I should have find the word part of it.
Okay, you're only human, Ruben.
Also, in the next page is the request form they should use, and one important part of this request form is it will require the signature of a LIN leader. Okay, so that LIN pretty much approves of what training is being attended and who's attending it. And again, this just as the sponsorship policy, any trainings that people attend or any trainings that are hosted need to support our project.
Is there a reason why this wasn't included in the LIN contract, if money was allocated for everyone?
It's different funding, so we didn't put in the contract.
Okay. Seems like you can combine it in one and have the form.
We could have. It was budgeted in different.
I get why you would do it separate. It's from different buckets.
We're making a policy for $5,000 for each LIN for the year. I mean, this usually a policy has to do with how we're going to operate on a longer term basis. Are we looking at, I mean, you said $5,000 a few times. Can this policy be useful if other money's available? You know what I'm saying? Is this limited to this little piece of money that you're talking about?
That was our intent with this, yeah.
Well, that's what we allotted.
Well, and it's attached to a particular funding category, correct? I think that's the rationale, Les. I think
So
it lives
next
inside
year
of
we
the thing.
could budget into this budget category, and this policy would still be useful and valid.
I would think so, yes.
I would agree with that.
So I guess what I'm saying is that
Yeah, I know what you're saying.
I think it's bigger than just, this is how we're seeing it for this application.
Right.
But it really is it a solid policy for us to use?
Yeah, I think it,
I think it could be.
in the future, right?
Sure.
Budgeting, yeah.
Okay, that's,
okay, that's good. Thank you. So that's your recommendation. We have I would entertain a motion again to advance the Lynn training request form and policy as it's been prepared by staff.
move.
Second?
Second.
Thank you very much. Any additional conversation, comments?
Who was it that moved?
Me. Not what?
Not Wes, Les.
Okay, so, hearing no other questions or comments, all in favor?
Aye.
I'm trying to get out of the way so you could.
Any opposed? Motion carries. Thank you very much. So now we're done with the action items. Are there any other action items, Carol, that you all would like to bring forward? Thank you very much. Okay, so we're into discussion. Next item is in here is Wes and Lauren. Numbers needed to treat and distribution of GCMH funding.
So a little bit of background on this. This is part of an analysis that we had done previously. To be honest, in a previous analysis, I had to extrapolate a lot of data to come up with the numbers. These are based on actual numbers. Let me give you some background around numbers needed to treat. So paper performance has all those metrics in that table that we looked at just a little while ago, where we highlighted the metrics that related to opioid use disorder. They're all rates. The rate has a numerator and a denominator. The denominator relates to the eligible population. The numerator typically relates to an event such as a treatment or something that we want to achieve, or in terms of utilization, something we want to reduce, like ED utilization or inpatient utilization. So HCA is holding us accountable to baseline performance, which relates to this yellow column here. Baseline performance is our performance in calendar year 2017. So again, that's a rate, and the numerator for that baseline performance is where we start off with, and then there's an expectation that we'll achieve a target. The target is also a rate with a numerator and a denominator. So the difference between the numerator in the baseline and the numerator in the target, the difference between those two numbers is what we call the numbers needed to treat. So let me just give an example. Let's say that we're looking at hemoglobin A1C for the population of individuals who have diabetes. Let's pretend there's a population of 1,000. The rate is 10%. So out of 1,000, 100 individuals are receiving that particular treatment or that particular diagnostic measure. So again, 100 over 1,000, HCA wants us to achieve 15%, which would be 150 over 1,000. The difference between 150 and 100 is pretty obvious, right? So we have baseline target. I'm going to go over two different targets. The first one, which is most important, which is this table that has baseline P for P measures in the title, relates to the measures that we need to achieve to get paid, as Carol talked about. 2019 is the first year where we're held accountable to pay for performance. 25% of our funding for this year, 25% comes for pay for performance. So in these tables, you'll see green and red. This isn't so much important from HCA standpoint. They're more concerned about the ACH performance. Where you see things that are green, that means the number needed to treat is to our benefit, which means we're doing better than the rate. And this will become particularly important when we look at the statewide targets. Where it's red means we've got some ground to cover. Is there any questions about that part? So in general, for paper,
Darlene has a question.
I'm sorry, Darlene.
Well, my question is a real specific one. Under mental health penetration, you don't note the under 6 population. And I know we've recently had conversations with both the healthcare authorities and some of the MCOs as well about how underrepresented that population is, and particularly that population when it comes to more intensive services like WISE. And so my question is, why would it not be on here with the under 6 population for penetration?
Because healthcare authority didn't provide us with those numbers.
Okay. Because part of the numbers they provided us with is kind of like what the penetration is for WISE across the state, which is extremely low. And so they're wanting to obviously have increases in that. Is it something that we could get from healthcare authority and that could be a part of this?
We can ask for it. A lot of these measures translate to the Healthier Washington data dashboard where they're reported, and some of those measures are broken out by those age cohorts. I mean, we could always ask to see if they will turn that out, but this comes from them through their measure set that is built up on MCO claims. All the information on here doesn't come from EHR. I mean, the information at the provider level is aggregated there, but it comes from claims and billing. So they get the claims feeds from the 5 MCOs, the 5 managed care organizations, and then they run these numbers to measure our performance, simply because that's the easiest thing to do. There's another set of numbers that relate to pay-for reporting I won't talk about today, but we're responsible for reporting as an ACH. We report that information up to healthcare authorities. If there's additional information that we would like them to report on, we can ask them.
It would be, I think, at least good to ask the question.
Would you mind following me up afterwards, Darlene, and we'll see what we can do?
So if we.
This is good.
I'm sorry. So, there's a lot of things that I think would be good to look at. I mean, I haven't really read this material, but I'm sure there's other things. But this is what we're going to be reimbursed on. This is what's going to account for us getting the amount we need.
This is what we need to achieve in year 1.
Yeah.
Not the whole project. This is just year 1.
So if you added something, it would be for our benefit, not necessarily for our achieving our pay for performance year 1 goals.
The number needed to treat are what we have to move to get paid under pay for performance.
Okay.
Other questions about this? So in general, the numbers here more or less represent about a 2% change. And that's actually fairly reasonable. 2% change movement in just 1 year. That means 2% decrease in ED, 2% decrease in inpatient utilization, 2% increase in hemoglobin A1C testing, 2% increase in diabetes, kidney testing, et cetera, about 2% per year. Another thing to think about here is that each number represents a client. It's a service, but it represents a client. That is also true. This is I didn't believe this until I looked at another analysis, which we won't go through today. Actually, it's in this table that's been sent to you. But ED visits also represents a client. I was thinking that number was really high. There's a lot of high utilizers. You divide it by some number to come up with the number of people. Some analysis that we've looked at really shows that ED visits is a 1-for-1. One visit translates to 1 person. So those numbers are high for a reason. I'm going to look at another table here in just a minute. There's a lot of uses for this information. Obviously, this tells us the outcomes that we have to achieve, but it's also important for strategic and programmatic planning. As Diane talked about, Lauren, you can scroll down here. Here, you'll see this number 77. As we had talked about, substance use disorder treatment penetration for the opioid resource networks, and coming up with the numbers that were tied to that particular RFP, we listed 100. So if we can achieve success there, we'll be able to cover those 77 individuals. That's what we want to try to do. So this is the first report. This is what we need to do to get paid. Let's go to the second report, please.
So West or less or whatever. Is this a subset of what we're being measured on, or are we indeed failing on every measure?
So it's not a matter of failing. It will, that first, well, we've gone on to the next report. We don't have to change back. Remember, the number needed to treat under paper performance was all red. It will always be red. It will never be green. Healthcare Authority will always expect us to make positive improvement.
Okay.
It'll never be green. For this report, it's a little bit different. So here, this report that says baseline comparison to statewide rates, we're not comparing to the P for P goals, we're comparing ourselves to the statewide average. So this is the whole state of Washington, all the ACHs, all the claims from all the Medicaid members. Now granted, this particular ACH is more rural. We're comparing ourselves to Pierce County, King County, which is obviously very, very urban. So here there's some really interesting things to look at. If we could scroll up to the top. Thank you, Lauren.
I did that on purpose.
Thank you. What stands out here, far and away, and this is the drum we've been beating since 2017 and earlier, is emergency department utilization.
Yeah.
Compared to the statewide average, if we were to reach the statewide average alone, we would have to reduce ED utilization by 41,000 visits. 41,000 visits. Now, as an analyst for a healthcare organization early on, I've seen pricing around this. Carol and I went on the internet. You know, an average price, and this is probably a little bit low, an average price for an ED visits is around, and Brian can certainly inform us on this, it's about $1,250 to about $1,500 per ED visit. You multiply those numbers by this 41,000, we're talking about $50 to $60 million.
That's why we like the air so much. I mean, I can't speak to everybody.
Right, Brian's like, what's the problem? Yeah, it's a big deal.
Now, if we go up and down here, actually for acute inpatient hospital utilization relative to the statewide average, so this is a conversation beyond just the transformation work. This is just a general conversation about, you know, the state of healthcare utilization across the ACH. We actually do okay. As far as adult access to ambulatory care, we do okay. As far as child and adolescent access to primary care, we do okay. If you scroll down some more, most of these are relatively green. Keep going. Again, ED utilization, but follow-up, medication management, we do okay. So again, paper performance, we're always going to have to improve ourselves, but when it comes our performance relative to the state, ED visit is the issue at hand. So this analysis is provided to you as just some information about what we have to achieve in 2019. We've got some programs in place. Patient-centered medical homes, Pam and Jenna and Martine are doing a great job. We think that this will have a direct effect on that. We think the opioid resource networks will have a direct effect on that. We think the Health Commons work in Kittitas, Tri-Cities, and maybe elsewhere will have a direct effect on that, as well as some of the other things that we're achieving.
You know, Les,
to
be fair, I there's a guy at work whose name is Wes, and you're just screwed from that one. I'll never get it right. So Wes, so one of the things as a hospital guy, we do a lot of work, and I mean, even in my orientations at work, I see, we talk about our ER rates, and we know what we see in the emergency department,
right? And
then we also look at our primary care, right? And so
we
actually gauge one of the community resources that we try to deploy is how do we know we got to put more primary care in place? And the reason we know we got to put more primary care in place is because we got these high utilization in what is clearly primary care in our emergency department.
Right.
I think some of it, there's a lot of pieces to this. I mean, because it's more than just that. I mean, you could put a whole bunch of primary care centers and a bunch of urgent care centers, and people are still going to use your emergency room for diaper rash, and they do.
No, you're absolutely right.
And so it turns in, there's the group out of Yakima that moves the patients out of, or kind of helps people navigate out of the ER. Consistent care. That's a very good project, and that's an opportunity to leverage up, I think, to help move some of these numbers. I've always thought that was a very, very strong opportunity. So one that we should probably really get after, and replicate as often as we can. I say that, but yeah, and there's other ones. There's lots of different.
Also
some of it's cultural. There's a lot of it.
But there's also the insurance companies now have health advocates, and they help I guess they're doing the support piece. But they'll come out to their homes, they'll talk to them about their health and find out what their disparities are, and they'll help them get into the services they need. They also do the calls. And I know that when I was with United Healthcare, I had this woman constantly at my phone. I was like, look, I already know how to do this stuff. And I had to let her go because I know that there's people out there that aren't following up with their doctors. And this is a good push to help those patients that kind of traumatized about the medical system actually get their feet through the door again and get connected. And that's the biggest issue. When you see a lot of the utilization of the emergency rooms and the emergency services, it's because there's not the supports in place in real life. We can talk about it all day long, but until that's met, you're constantly going to see these numbers like this.
Right. I mean, this is an endemic issue that's going back to the 90s. High utilization has just been a fact of life. And when we compared us to Puget Sound, which is actually very efficient, there's always been really high numbers here as part of the medical community. And, Brian, like you're alluding to, there's no silver bullet to address it.
No, there really isn't. And frankly, some of the stuff that we've done in an effort, much like the opioid program, right? Part of the reason we have an opioid problem is because of our demand to resolve pain.
Right.
We legislated that you resolve pain and created this other problem.
Right.
We've mandated, and aside from anybody's politics, I mean, it's good to expand Medicaid. This is a repercussion of that. I mean, they're just all part of it. And that's why we're all here, really. If you get right down to it, it's about reducing the cost of Medicaid. Well, it's all good.
Right.
There's a lot here. So this is an excellent report. This is the first time I've ever seen all this stuff pulled together as effectively. There's a lot here. I think we spend a little bit of time working on it. We'll come up with some good stuff.
Julie?
Is this, so I understand the data, are these, in my case, Kittitas County zip code residents, or are these visits in an ED in Kittitas County?
So first of all, this is just Medicaid data. It's not commercial. It's not Medicare. It's not military. It's for individuals residing in those particular.
So it's beneficiary level data, not facility.
Right.
And then looking at how far off the ACH is from the state average, how do they determine the sort of trajectory of improvement? Because that's very modest compared to where we are relative to the state average.
Trajectory of improvement.
Right. So what they're saying, our numbers we need to meet here are very modest compared to how far over we are.
So yeah, the paper performance measure. Why don't you go back to that first slide? So again, Healthcare Authority took a very modest approach. You'll see two things here, G to G, which is gap to goal, and improvement over self. Improvement over self, they essentially said, whatever you're at, improve 1.9%. As I said, it's about 2%. No matter where you're at, make a 2% change. Gap to goal, what Healthcare Authority did was they went to NCQA HEDIS measures, and they found, and I forgot what percentile they looked at. They looked at a very high performing system, and they said, here's the high performer, here's your ACH, take that distance and divide it by 10 and look at the first 10% improvement. Okay, so the distance to the high performer, move 10%, which actually works out to be 2%. So that's how they did that calculation. So it is a bit artificial, but it's meant to be reasonable. If they were going to say, we want you to do a 10% improvement, let me tell you, that's just not possible.
Yeah, no.
That's not possible.
We can go home now.
Yeah.
Okay.
So currently, I know it's been shifting some, but the way that hospitals operated in a way was you've got to get people into your ER, which will get people into your beds, which will pay for your hospital.
Mm-hmm.
So the real emphasis has been getting people into the ER.
Mm-hmm.
Right.
Still how you get paid.
To the,
I mean,
so,
it is.
so,
Yeah.
so we're talking about telling hospitals, we're going to take $50 million from you guys.
Mm-hmm.
And so what I'm saying, our system.
That's why it's such a popular notion. We don't like it.
Okay, so I'm just saying, we're really talking about trying to do things, we're swimming upstream. We're battling against the current to try and get somewhere.
One day we talked about, and you're right, but one day we talked about, the little steps that make big differences, right, over a long period of time. And I think that's really what the answer is. I think Wes shared, there is no silver bullet to this. We've created our own problem, and it's okay. You just got to develop and work. So yes, it's an uphill climb, just like it was when we all decided to quit smoking 30 years ago. Nobody was going to quit smoking, but we all did, and it was an uphill climb a little bit at a time. So I think that's really the way to address these things is it's replace and fund. I can tell you my hospital gets it's a 25-bed hospital. We'll admit 6 patients a day through the emergency department. I'll admit 6 patients a day through the emergency department if I see 70 patients or if I see 12, as long as I see the right 12.
So
I get paid for the other ones too.
Yeah.
So I've got to find a way to get those guys shifted into something else that pays me, perhaps not as much because it doesn't cost as much. Do you see what I mean? And I think that's what this goal is.
So, just to add something here that I've heard from a consultant that I've talked to, rural hospital providers, particularly critical care access hospitals, because they've got a break as to how many inpatient admits they have. They spend a lot of time focusing on ED. It's margin. I will tell you, this consultant that I talked to that had talked to somebody at University of Washington Hospital. They have done a lot of analysis of Medicaid members, and particularly individuals that have really complex needs, and they say that they're a money loser. They do not profit the hospital.
No, they don't. What happens after the ER is what's profitable.
It gets to be very, very expensive. So, there's a sustainability issue on the part of hospitals here that we have to be sensitive to. But at the same time, focusing on that top 5%, which we continue to go back to, we all can agree, let's just try to focus on those. I think that's part of our sustainability discussion, which this board is going to have at a future date. How do we come together to tackle that very difficult issue? Ron, I didn't mean to cut you off.
Oh, you did, but that's okay. It happens.
Well, I'll just go back to, you're right, the savings you're talking about is a reduction in revenue to hospitals. But going back to the work that Franklin Community Health Alliance did with Carol back in 2010 and the Washington State Hospital Association, every hospital in the state has been all in for 9 years in trying to reduce inappropriate utilization of ED. That's no way to sustain your system.
Right.
So I don't think I'm sorry.
No, I'm cutting you off. I was cutting you off, but that's the key, and that was what I was going to speak to, is that it's not so much that there's utilization of the emergency services and rooms, it's the improper use of that, using that as your PCP.
Mm-hmm.
If the PCP wants and needs this client to go into or patient into the hospital because there's a heart condition, there's something going on, and it's got to be done within the hospital setting. Ideally, those folks are going to use the emergency room if there's a condition that promotes them needing to utilize that emergency service. But if somebody's coming in with just a cold, a stub toe, I had a broken toe and I didn't go to the emergency room,
my doctor said, why didn't you go to the emergency room? And I was like, because it's broken, there's nothing you can do, nothing they can do except give me something for pain, and I've got Advil at home. You know, but people don't always in general think that.
Right.
But that's the other part. Our providers, and this is another thing that's changed in the last, I don't know, I can tell you how many years I've been doing it. Now I call a provider in the evening and it's go to the ER. They don't even want to talk to me about it. So that I'm saying there's some other things that can help. If we get to really get to this primary care system, we're going to be talking about someone who's going to be able to answer questions and help me when it's not convenient.
And Jenna and Martine, the patient-centered medical home model requires a nurse line, correct?
Yeah.
So, I mean, again, putting those things.
I think we're making steps, though, from moving from reactionary to being proactive when it comes to primary care. I just think, just like the hospitals have a challenge, primary care has a challenge. We don't have enough providers, so we can say we're going to build a clinic, but we don't know if we're going to have a doctor to work in that clinic. And so there's still those workforce challenges that, like, we haven't reached the breaking point of when we can kind of cross over that hump where we have the provider capacity to match the need. But we are, even though we don't have that, we are still being slowly pushed and guided to make the changes that we need to have those nurse hours. For the Medicaid population in particular, you know, we are, in primary care, we're held accountable by our managed care organizations to reduce ED utilization. It's part of how we will continue to support our systems in the primary care side. So it's those little changes that are all happening. We just haven't hit that critical mass where we can actually even out and really start to see the big difference. It's just a longer term process than what the waiver timeline allows for.
Well, Wes, I appreciate the work on this. This is an excellent document. We'll spend a lot of time going through it, I'm sure.
Yeah,
it's very
we'll
good.
come back to those numbers too.
Thank you. We do have to get moving on here. So the next items, are there other thoughts, comments? Thank you. The next item, GCACH committees, is Lauren.
So Carol, did you want to talk about your table first for PCMH funding?
No, you can do the committees and then we'll talk about that.
Okay. So last board meeting, there was a request to have a list of all of our committees and work groups. So I created that list. The first page maps out all of the committees that report to the board, the committees that report to the Leadership Council, subcommittees, and then the second page is a description of the committee. So this is just more informational. If there's any committees that any board members want to be a part of, you can let me know and I'll make sure that calendar invite gets sent to you, but this is just informational.
Can I interject, Lauren? We're still looking for 3 now more members. There was 2 last month. We lost another one. We need 3 more members for the Budget and Funds Flow Committee. And
I'm not good only at home.
So I last month I asked for recommendations. I didn't get any. This month I asked for them again, and they still haven't received any. So I'm hoping you guys get help.
So
Add me.
Okay.
Julie, yeah.
So the Budget and Funds Flow Committee is supposed to be including, is just the board, sub-board committee, or is it other?
Yeah, no, there's ad hoc members on the.
Yes, there is. Yeah, it doesn't have to be a board member, so it could be, if you have someone that wants to participate.
So if it's not me, then
Yeah.
I CFO will.
Exactly.
And it would be good to do an orientation. If those 3 members come on at once, it would be good to do an orientation because there's a lot of data.
Yeah.
Sure, we can do that.
Agree. That's a good idea.
Right. So what I asked for at the Budget and Funds Flow meeting was a little bit of background of what the person does. Well, not for you, Sandra, because I know, but Julie, if you bring me somebody, what their credentials are, not their resume, but what they, what they do for you, what they could potentially bring to the Budget and Funds Flow Committee. Thank you, guys.
Good.
I do have a quick question on that. Are we saying that the Funds Flow Committee is a subset of the Finance Committee with that chart?
Yes, if they make recommendations to the Finance Committee.
Okay, they make recommendations. Doesn't mean that the constituency should be a subset of.
No.
Correct.
Okay. All right. Thank you.
Thanks, Jorge. That's good.
Thank
you.
Hey, Dan, where are we at in the
Mhm.
workforce committee?
No, I don't think so.
Where are we at?
Yeah.
Well, we just met, as part of the Lynn, training, last week.
Because I haven't been able to attend due to work.
So, we did actually a fairly robust training for, the Lynn leaders.
Okay.
Actually, I do have one more thing to note. We're looking for more members for the communications committee as well. So if you're interested, we have some exciting work in 2019 that will be coming your way. So if you want to be a part of that exciting work.
Oh, it was budget and fund law.
Actually, yeah, that's, so, Ruben's ACES campaign is now reporting to that committee, and then work that we're doing around Consumer Resource Directory is reporting to that committee. And I mean, Lauren's right, there's potentially going to be a marketing committee to some extent, so.
We have a retreat in Hawaii next November.
I thought it was at the end of this month.
I thought it was a temporary member over there. I'll be right there.
Okay, excellent. Thank you, Lauren. 2019 timeline.
Actually, we're gonna zip through some of these next few things because there's a couple of things on the discussion items that I think are really important to the board, including the Yakama Nation and stuff that land. So we're not going to take a lot of time, but Lauren was kind enough to place on this map where all the clinics are located that are involved in our patient-centered medical home initiative. So you can see they're spread out between Cle Elum and Pullman, pretty nice spread across the region. So we were really happy that we're trying to reach all corners of our service area. And then I just did a really quick analysis and taking a look, so where is the funding going? And this is primarily the provider engagement and the PCMH funding. So here are the numbers. You can see that Asotan's receiving $240,714 and Yakima's receiving $3.6 million. But when you take a look at the percentage of funds as they relate to the percentage of Medicaid clients, you can see where some of the counties are a little bit under and some are a little bit over. Probably more particularly Yakima, even though they're getting the $3.6 million to date that has been distributed, or that will be distributed throughout the year, they still have 45% of the Medicaid clientele. And we just bring this to the board's attention for future planning, for future projects, and when we talk about sustainability. So just as a point of reference. That's what we wanted to say about that.
Okay, thank you. I think you're on the next one too.
And then at the last month, we handed out kind of a schedule of activities that would be happening throughout 2019. Wes was kind enough to put this into a project work stream diagram, so you can see that there's a lot going on. Again, now that we have the PCMH initiative underway, we can do other things and address other areas that really relate to health, but relate more to social determinants of health. So across the top, you can see kind of the schedule for the learning collaboratives and practice transformation with the deliverables and the subject areas that will be covered during the collaborative. The second row is the Medicaid transformation project. So you can see that's where the opioid summit shows up, and we're planning on a transitional care summit in August. And then there's some of the reporting that will be required of the opioid research network. You can see all of Wes's HIT projects and when those are scheduled to start and what those entail. We have some miscellaneous projects and meetings. So the housing summit shows up under March, and we've got some of the Lynn workforce training meetings on the schedule. The launch of the ACES campaign. So you can see how that's, working out. We have a board cultural sensitivity training in September of 2019, and then the final column is really about what our payment schedule looks like. So we're anticipating that our next payment for the STAR 2 and our implementation plan will happen between May and June, and that should be around $17.5 million, which will be our next huge influx of money. Hence, we bring these other opportunities and ideas to the board just as food for thought.
So just one additional note to what Carol said. In that second horizontal line from top, you'll see where it says C1, C2 in front of all those individual items. C1 relates to the first cohort that's currently going under practice transformation through the patient-centered medical home. So that process is in place. Most of those milestones relate to reporting and then subsequent review by the practice transformation work group. C2 relates to a potential second cohort, which there'll be some strategic planning around as to first of all whether or not, and then if so, then who.
Mm-hmm. Okay. Very good. Thank you. Next on your parade there, Carol.
Okay, so just the Primera letter?
Yep.
Okay, so you might recall that in early November, Ruben Peralta and I met with the Camber Collective. They were hired by Primera to look at areas of potential funding for the ACHs. And we started, they started in Pullman and they met with Scott Adams and Pullman, and then came down to Garfield County where Ruben and I met with the Camber Collective.
And West Side, you were there.
No, I wasn't.
Oh, sorry.
No worries. No worries.
And so we just recently received a letter from Kitty, who is really kind of the spokesperson for this group, to say these funds are going to be let pretty soon. Here are the 4 program areas that we are going to be addressing: the physician and nurse recruitment and training, clinical integration of behavioral health, provider-to-provider consultations, and crisis stabilization infrastructure. And I think that the last one, Tanya, really relates to the meeting that we had with the Yakima Nation and the difficulties that they were getting with their crisis services in Yakima. So the question that we'd like for the board to consider is, how do you want us to approach this opportunity? Would this be a joint effort, and that we do have funding set aside for a grant writer, that we would collectively come up with a list of projects that we request Primera funding for? Or do we just send out this opportunity to all of our partners and say, go for it? You know, however you want to access the money, here's a Primera opportunity. My sense is that they would appreciate a more collaborative approach, a more regional approach, since that's the way that they went out and met with all of the ACHs, was more of, from an ACH perspective, what are your highest needs? And this is in particular for the rural areas.
And as the letter indicates, more details on how to apply for this grant, it's coming up in the upcoming weeks, and this letter was written on January 30th. And one requirement I do remember them mentioning is that whoever applies needs to show that they have some other type of funding. This should not be like the only funding they get.
Mm-hmm.
And you know, just looking at the 4 areas that they want to support, it really aligns with what ACHs are doing, because they visited several ACHs and they got the tours from several ACHs, and it really aligns well. And they also have another bucket that's social impact, and that is almost entirely directed towards ACEs, towards resiliency programs. So that other bucket is also a good opportunity in addition to this one here, this one's mainly rural health.
And do we know how they're defining rural?
Not the Tri-Cities, because they didn't stop by.
Well, so we met in Garfield, and then we met in
Pomeroy,
Dayton,
Garfield,
Dayton, Pomeroy, Coffinish,
Yakima Nation,
and Yakima.
Yeah.
Where we met.
So I guess I'd get a little proprietary on behalf of what I would consider rural, and I'd be happy to define this for them. But, I mean, there's as many definitions for rural as there are folks out there talking about rural. I do think there are, in some of the places you've talked about, Toppenish, Sunnyside, Kittitas County, some unique needs. So I guess I would promote a collective approach to Primera, but collective on behalf of some of our more rural needs.
Rural meaning?
Well,
way out.
Well, not Frontier, but some of the folks you've mentioned, and I'll make the pitch for Kittitas, but Garfield, Pullman, but they have very different needs than core Yakima, Tri-Cities type of needs. So, programs are not necessarily scalable. So this really is a great opportunity to leverage some additional some previous funding, additional ACH money with this Primera money.
And I think that's, Ruben hit the nail on the head, is that the leveraging comes from using the funding that we have already disseminated to a lot of our partners and saying, we're already doing this. We told them about our community health fund. They were very interested in the community health fund and how we were pushing money out to our partners. So again, any of our partners that receive any of the community health fund, we can leverage.
I think the Health Commons project is just teed up beautifully with the Primera program.
Yeah, I do too, and I agree with what you're saying about how many different variable definitions of rural. When I was in West Palm Beach, Yakima was rural because there's 4 million people there, right? So it's different.
The other thing is it's not a countywide thing. I mean, Cologne, Starbucks, Starbucks and anyway, but Close and Star in Franklin County, and they're not very close.
But to develop a really, meaningful strategy that are actually going to make an impact, is going to have this kind of collective.
Yes, I agree.
Critical mass of work together. So I think more of a collective approach is probably warranted.
So when you say critical mass, what do you mean?
Well, I mean, so people in Starbucks aren't going to be able to focus on clinical integration and behavioral health. I mean, I don't.
But the Tri-Cities is not going to be able to do it for them either.
Right. Yeah, and so encouraging kind of collective, bringing people together to work on both, kind of sharing infrastructure and expanding.
So, Carol, what is it that you need from this board? Do you
Well,
need?
I mean, I think what I'm hearing is that we would rather have a collective approach to the grant opportunity as opposed to just sending it out to the universe to say, here, go for it. And so what we will do is that we will work with our providers and the board, to come up with some kind of a package. Once we get the RFP, that we can have more,
I think it really depends on how they shape that RFP, because collective may or may not be the best approach, but we won't know until we know their rules.
Right.
Yeah.
Okay. Well, I think that's appropriate.
Okay,
I think those are good marching orders.
And just one more thing, one thing that I remember from the different people we visited, several of the communities we visited, they asked a question about how cumbersome is the RFP process going to be, because they mentioned they don't have the resources, they don't have the time, they don't have the money to pay a grant writer. So they asked for that process to be simple. So let's see what it looks like. And so that also makes a good case for it to be a collaborative process for like us who have already allocated some funding for that purpose. We didn't know this was coming, but we had allocated some funding for grant writing.
Yeah, I think that would be a great use for the project.
Okay. Next item. Carol, was the Yakima.
Yakima Nation is a separate land. So as we talk about these funds going out to the land, and we know that we have Yakima as the Yakima Nation as a partner, and we have funding set aside to them, and they're still determining exactly what projects they want to pursue. The question came up actually from Ruben is, so how do we allocate scholarship funding for the Yakima Nation if they want to take advantage of these trainings? And so we had a conversation that happened within the communications committee that it seems to me that if we're going to recognize the Yakama Nation, that they need to be a part of LIN, or they need to be their own LIN, or there needs to be some equity in the way that we're allocating these funds. Because beyond patient-centered medical homes, we have been trying to push out funding to help these local health improvement networks get up to speed, to come together, to bring various sectors across their communities to start working collaboratively. We've been working with Yakama Nation. We had several meetings last year. I don't know even how many we had with some of their program leads. And I think that there's strong interest, at least in talking to Arla and Washington last Friday, there's a strong interest for them to kind of become their own LIN, so that all of their own program managers would have this opportunity to gain from each other all of this knowledge and to share, you know, information and share resources. So I had a meeting with Arlen last Friday. I proposed this idea of having a separate LIN. And as you know, the local health improvement networks all work under a contract. So there's performance expectations. It's not just free money that we say, okay, here you guys, there's $30,000, do what you want, but it comes with a list of requirements. You guys saw the contract today. So there's certain performance measures that we expect of all of our LINs, but in return, we think that we're trying to help them get set up to become kind of their own mini ACHs. So the question is you know, how does the board, how does the Yakama Nation want to be incorporated into this structure? Because to date, you know, I don't think there has been a formal agreement between the Yakama Nation and the Yakama Healthcare Coalition, which would be the closest LIN to them in terms of, you know, how they're being brought together and how we're sharing that kind of information. And Tanya, I don't want to put you on the spot, but just to let you know that, you know, Arlen was really supportive of this idea of having, you know, the program managers come together on a monthly basis or a more regular basis to work towards some of these project areas that, you know, you're familiar with, and work towards some of the goals that the other LINs, you know, have in front of them too.
And he actually already holds monthly meetings with our program managers. And so I could see him probably keeping that in order and keeping it on a functional basis for the tribe. I just hope that, you know, within our own tribes, we can be very selfish in some ways. So I just hope that they can come to a consensus. But I think that it would be helpful because not all of our programs are tribally funded. For our program, for instance, we're strictly off Medicaid and 638 grant. So if we're, again, I think I've said this, if we have a schedule of 8 clients and we're only getting paid for 5, we're hurting. So we lack the funding to travel. I don't think I've traveled for maybe 4 or 5 years, but that's also because I'm very busy. And so I don't travel unless it's local or I can drive there. So the training options, but we do have a lot of grants in our behavioral health program. Kathy is like this really, really awesome grant writer. And, but as far as that support, so I think it'd be worthwhile because we have housing, we have a housing authority, and we have a really huge homeless issue right now to where like Toppenish and Waco, there's areas that they would live when you cut all their trees down and everything, so now they're just aimlessly wandering around the town, and they're kind of getting more aggressive. We do get some of them in for mental health issues, but not all of them do come in. We opened up the armory in Toppenish because the tribe owns it to shelter them through this cold, but that's only through the winter. We put up mini homes in our RV area, but everything again, if they're using, they still get those available to them. So we have the same issues. We have a housing, we have the clinic. I mean, so there's a lot of things that we do have that we could probably, you know, be able to reach out to our population a little bit more, because I think what everybody needs to understand too is when we talk about the nation, we're talking Clealum down to the river, or, you know, almost over here. I mean, our reservation covers everybody. And so we have a huge population that we have to cover. And it's just been a resolution that within our programs that we have to reach out to White Swan and we have to reach out to Golden down to the river. So if our programs do anything, even if we don't have funding, we have to do that. So any kind of support that we could get in making that happen would be great.
Okay. So do you want to, it sounds like something we should probably seriously consider, development or create an opportunity for a land development over at the Yakima Nation. Would you like a motion from the board? Is it appropriate for that yet?
Sure. I mean, I think, you know, Arlen said he would have to take it to the elder, the tribal council, to get, you know, authorization to form a formal LIN, and it does take a contract in order to formalize that relationship. So it would take, I think.
But you have the mechanism to do that, whether the board says, hey, go ahead and sign that contract for this land, correct? I mean, you've got the authority to
We
do
do, but we don't necessarily have the funding allocated in this year's budget for
that.
that. So we would have to find the funding.
Is this a budget revision or is this, what is,
Sorry?
what would have to happen to make this happen?
Sounds like you got to identify the dollars.
Right.
Right.
And we
Can
probably
you?
just take it out of our design dollars, which is where we take all of our LIN funding from.
Okay.
Would you guys be able to do that?
The board determines the funding and where it goes, so.
Guess I would motion that we have staff begin that exploratory process of finding the funds to establish Yakima Nation land
So I'm thinking
and
too.
report back to see if that's going to work on the budget, and then proceed from there. Because I just know, based on just things that Tanya has shared in the past, how difficult it can be to say, well, this is my opinion, but I don't necessarily represent the tribe, and giving some formality to that might be beneficial to our group and our discussions long-term, the next couple of years. So, my motion.
And I think the money is important, but if I'm hearing Tanya correctly, technical support, what if that means to be of land from the Greater Columbia would be even more helpful than, or as helpful. Money's always helpful, but as helpful.
I think Carolyn would kind of know how our, you know, the IT part goes with our program. It's terrible.
And that's another area that we really would like to make some headway in. Maybe sort of kind of a little bit like the health commons, but it's probably going to be even more basic than that.
Okay. Well, let's start at the start. I think you're right. Start an exploratory, figure out what it needs to look like, and bring back recommendations.
All right. Thank you.
I think, wait, was that a motion?
Yeah, that was a motion.
Second. Thank you.
All in favor?
All in favor. Is anybody opposed?
Let's just go. What else should we get out of Brian?
Yeah, no, that's all right.
Brian!
So, it's good to be there. So, we have just a couple more minutes. Do you have anything that we got to talk on survey results and when
I think we can wait till next month to do that. Unless, does when 211 need something today, Lauren, or Wes?
I don't think so.
Okay, we'll push that into March then.
Okay. Excellent. Well, anything else for the good of the order? I would accept a motion to adjourn.
So moved.
All in favor?
Aye.
Thank you.
Goodbye.
You have to walk to get it back.
Thanks, Jorge. Have a good day.
Thanks.
You're the only left one on the phone.
Thanks.
Maybe.
Hey, Laura, just leave it.